chapters. So please share on your social networks. And thank you, all of you who are watching us. Everything that you are watching today is going to remain recorded on YouTube so that you can watch again. Thank you very much. Paulo Freemind, this is his new name. Ladies and gentlemen, and dear friends, it's a pleasure being here. I'm very proud of having been invited again to be here. And when I was invited, I was really scared because I was told to organize a roundtable with the best professionals on depression and suicide. And I didn't know who I could invite, but I proposed a slight change. Let's talk about prevention. Let's talk about depression, but let's start by defining what depression is, and we are going to differentiate depression from sadness. Right after this, we are going to enter an area that is a little bit more complex, which is talking about the opposite of what happens after post-traumatic stress. How can we turn a devastating experience that could represent the end of a person's life to grow? Doutora Marina Lemos is going to talk about this topic. And then in the end, Silvânia Giandonio, who is a social worker, is going to tell us how she organized a community movement that involves all of the city's sectors in a real community focused program. I will take the opportunity to say a few words about prevention. Today, like happiness and quality of life, prevention means whatever a person wants. Prevention today, it is an activity that can be evaluated scientifically. There is a science that is called preventology, and I would like to show you the principles and models we use to talk about prevention. And then we're going to be able to talk about the evaluation of prevention programs. You know, there are people who are dedicated to drug prevention and programs and other prevention programs that they're so committed that they don't stop to assess what you're doing. If we do it with this mindset of a missionary, it is one thing. But those who work in the healthcare and social areas, we have to be careful. We deal with public money, public institution, and we have social accountability. So there are two models of prevention. It is a set of actions that prevent something from happening. We had the classic model through stages by Level and Clark's book that was published in 1965. I was a second year student when they published this book. And more recently, there's a different model, which is the evaluation of prevention by risk. Mazurek and Haggard published it in 1994. And the prevention by intervention phase was something developed by for infectious disease. When we deal with conditions that have a more or less clear reason, talking about it through stages makes sense. But for disorders that have multiple causes, evaluating through risk is better, and this includes depression and suicide and others.
So we have primary, secondary, and tertiary prevention, and prevention by risk, selective, universal, and indicated. These are the major types of prevention as per Haggerty and Marzek. In other words, you can call primary prevention as health promotion, specific prevention. Secondary prevention is what we use to call diagnosis and early treatment. And tertiary prevention is what we also call rehabilitation. I'll skip this one because this one is more interesting. So just picture a disease, which is that blue bar at the bottom, that starts at the age of 20. It will have its peak at the age of 30 and then naturally decline. If we want to talk about the prevention of this condition, we have the pre-disease period, where we have primary prevention and then secondary prevention, and then we have the healing, the convalescence, which is after the tertiary prevention. In the risk approach, we have three types. Universal, for people with no risk. So if I want to prevent suicide in this room, I have to talk about universal prevention because I have no idea what's your risk of suicide. And universal prevention addresses all risks, from no risk to all risks. Selective prevention, however, is aimed at people with a low risk but some risk, people who are prone to having that condition. We can think about drug users, alcohol users, people in suicidal crisis, people at risk of depression, people at risk of COVID. Anything can be a trigger for that. And it's indicated for people with a high level of risk, people who have been identified as high risk, people who already abuse drugs, alcohol. Those people are eligible for indicated prevention. Another condition is the bipolar disorder. The lithium users also is indicated for people who have this disorder. Talk about use patterns. It's important to notice that we have 5 patterns of substance use. No use, experimental, occasional, intensive, dependency. And when we talk about each level, and when we talk about drug prevention, it's important to think about all levels. We can, what level we're talking about. We can talk about absolute prevention, expecting everyone to become non-users, or we can approach the experimental, the occasional, the harmful, or the dependency use. So it's important to specify what we're talking about so that we can adopt the right approach. For example, when we talk about so according to Gordon's approach, let's talk about drug prevention or alcohol prevention in schools. The universal prevention is for all students, and then the goal is to prevent or delay the start of the use, the content, skills for life, education in general. When we work with suicide prevention, we never talk about suicide in school, and we shouldn't talk about drugs, specific drugs in school. We should talk about the values of life and education in general. This tends to work better in schools. When some students are already at risk, we have to prevent the start of the consumption, because we know that these students are more likely to start consuming drugs like alcohol and marijuana. So we have some specific interventions directed at some prevention factors and risk factors. And finally, there's the indicated prevention that is for students who are already users. There's no point in telling them not to start because they have already started. The goal is to reduce consumption, prevent harmful use, and then we need individualized programs or programs for small groups focused on their specific needs. It's different from talking to the entire school or the entire class. The individuals who are already using substances are different. This is the theoretical distribution of smokers by gender and age. You see, men start smoking before women. The surge, the peak, it's pretty much at the same level. Women do not reach the same peak as men, and the decrease is the same, the decline is the same, but women quit earlier than men. If we want to do prevention, smoking prevention, specifically for males or specifically for females, we have data here, and this is what we have. Don't be scared. I know it sounds like a lot, but we have all these intervention models that some will try and prevent you from start smoking, some will prevent you from smoking too much, some will help you reduce the cigarettes you smoke, and some will help you quit. At different points, different approaches are used at different age ranges. So scientific prevention involves this type of approach, this type of study, this type of specification. And finally, if I can change the slide. There's the assessment, the evaluation of the outcomes. Any intervention can have any of these 5 outcomes. At the center, it's the unknown. I'm working on a program, but I haven't yet had the time to assess it, so I don't know what the outcome is. But some programs are over already, and we know that the results can be either ineffective, make no difference, a waste of investment, or we can have, or they can worsen. The individuals that undergo the intervention can worsen, they can go to worse conditions, or in some cases they can have promising results. Say the project worked, and then you need to expand the sample to see how it goes, and occasionally you may have an effective outcome. This is the responsibility of everyone who's willing to work with prevention. I admire those who do. I encourage you to work with prevention, but you have to think of scientific prevention. It has to be designed and planned in a more scientific manner. It kills me when I hear people say, "Oh, I really believe in prevention, but consumption is increasing, so there's something wrong," isn't there? Or you're either doing something wrong, or you're working with the wrong population, or you're adopting the wrong skill. So if you have this goodwill, please keep it, but let's try and improve the methods and the mechanisms we use to have increasingly greener or better results. And I know I have said a lot, but now I'll hand it over to Dr. Eurico. He is my friend, and I'm a fan. I'm not only a friend, I'm a fan. And I'm sure you're going to fall in love with him. Well, my responsibility has grown now. Speaking after you is not easy, sir. I thank you all for the invitation. I'm very happy to be here. I'm very happy to see so many familiar, dear faces here in the audience. So let me start from the beginning. Depression is a term that we use in everyday life. I'm kind of depressed. I'm down. Got the blues. And sometimes it can be confusing because it is actually a condition. Some things are normal. No one is happy 100% of the time. No one's happy all the time, right? Sometimes when we have to make big decisions in life, we feel sad and it gets us down. No one makes big decisions during carnival or during parties. No, don't, at least not very frequently. So it depends on the and depends on how intense the feeling is. We may think of a biological condition that is called depression. It's a disease. It's a disease, it's a disorder, it's different from sadness. This is a piece of furniture. It has many drawers. It's a chest of drawers. In psychiatry, we also build diagnoses and we put the diagnoses in various drawers, and from time to time new drawers are built, and some drawers become more fashionable, more used, some are forsaken, and you may come closer to this drawer and change the order of the drawer to make maybe you used to put socks in this drawer and now you'll put t-shirts there, and you used to have your jewelry in one and then you put your letters there now. A mental disorder is also a construction. And why is that? Because we learn over time. Of course, there are some biological causes that have already been identified, but we don't have a blood test or any imaging test. There's no such a thing as an MRI that proves that tells us that that's what's happening. That's what's happening. So everyone is today. Everyone feels like a psychiatrist sometimes because we've never talked so much about mental health. We've never seen so many coaches online 24/7 on social media. So, and that can be a problem. When we treat someone, when we talk to someone, we sometimes fail to see that. So we look at the symptoms, different pains, different backgrounds, different stories that come together and make up a single thing. But then sometimes we have to break it down into symptoms and data to inform the doctor's decision. That's how we make a diagnosis. So I'm going to try and tell the differences between these things. I know it sounds like a class. It is. I will actually even have some diagnostic tests with you later based on some stories. Let's hope it's not boring. Let's hope it works. So a little bit of history. First major physician who ever wrote about depression here in the West was Hippocrates. He is the father of medicine. The famous oath of doctors is the Hippocrates oath. He lived about 400 years before Christ, and Hippocrates firmly believed that our spleen produces a substance called black bile. We know it doesn't today, but in the past 400 years before Christ, they believed that our spleen produced black bile. And he believed that this excess black bile, which in Greek is... Look at how dangerous this is. I almost fell here. I'm sorry. So I was just about to become a meme, an internet meme. So bile in English is coal, and black is melano, right? And then melancholy gave rise to a beautiful word, actually, melancholy. That's the origin of the word. But no one talked about depression. Depression is the modern term for the condition he described as melancholy, or the black bile. This knowledge, this expertise was passed down from generation to generation, all the way up to the Middle Ages. In the Middle Ages, they tried to forget the Greeks, but Hippocrates was always there. In the Middle Ages, they believed that excess black bile caused depression. But again, it was during the Middle Ages that the Catholic Church called the shots. And among the sins listed by the church, there was one called acedia, and depression was considered a sin, because if you were a victim of acedia, you were being driven by the devil, and you rejected the powers received by God. And it was a strong notion of sin. Melancholy was strongly associated with sin, and the notion of sin also appears in the Middle Ages when we condemned suicide. they believed that that suicide was driven by the devil, encouraged by the devil. And this word, desperation, which means desperations, it had to do with the whisper of the devil in our ears for us to commit suicide. In this fresco by Giotto, he depicts the devil, always small. The devil is always small. It's most of the times it's small in these depictions from the Middle Ages, and there were many punishments. The corpse of suicidals were hanged and quartered and hung upside down, and they couldn't bury suicidals in holy ground. And then in the late Middle Ages, there came up the notion that that could be a mental problem, a problem in the head. And that's when we have this famous painting by Bosch, which represents the stone of madness. Today we smile like a stone in your mind, in your head, but that was already a sign of progress of the ideas and of the notion from the devil's instigation to something in your head. And of course, there were charlatans that would go from village to village doing trepanations outdoors, and they would hide a stone up their sleeve, and they would. This painting is actually about charlatans of the time that used to trepanate heads in search of the stone of madness, stone of sadness. Do you all remember your textbooks from school? Let's go back to the 17th century now. This book, with such a beautiful name, The Anatomy of Melancholy. Remember, Hippocrates was from 400 before Christ, and the word he used, you see how long this word lasted. Look at the strength of Hippocrates and his findings. So this is a very long book, 2,000 pages. It was translated into Portuguese, actually. You even was translated into Portuguese recently, and it was even received an award here, but that doesn't matter. Just look at this sentence, one sentence from a 2,000 book page. If there's a hell in this world, it is to be found in the heart of a melancholic man. This sentence disrupts all our beliefs from the Middle Ages, and says, is there a hell? Yes, there's a hell. Is that a hell with the devil and fire? No, it's inside of you. It's a major breakthrough. It's a major change in our worldview. So let's say some people, oh, he's melancholic. If you say someone is melancholic, you may say that this person is reflexive, analytical, sad maybe. Being melancholic is not a flaw. We're born. Some people are born cheerful, joyful, funny, extroverts, and some are more introverted, circumspect, watchful, quiet, sad sometimes. So, but it's a sad, but that sadness can turn into chronic bad mood. People who are easily annoyed and become grumpy. That's also a form of chronic depression that we called dysthymia. Some people have these characteristics and they can improve over time. They can improve with antidepressants. That's actually interesting. They can improve with medication, and we didn't know that before the 1980s. So if you're very grumpy, maybe medication can help you. Maybe, not always, but maybe. There was also this major confusion in psychiatry, and as of 1980, psychiatrists in the US got together and came up with a catalog of diseases with criteria to try and standardize the language. Very important publication, and you see, looks like a recipe, a cake recipe. So to tell whether or not someone has depression, it's mandatory to have a depressed mood or loss of interest in things they used to enjoy. For example, a big fan of Corinthians, Brazil's greatest soccer team, and then there's a game today, and the guy who used to be a major fan is uninterested. He completely loses interest in things that used to give him great pleasure, him or her. So Some people have this depression that is not sad. It's some sort of anesthesia, this loss of interest in things. You may say, "Are you sad?" No, I'm not sad. I just lost interest. No good hope for the future. No expectations for the future. I wasn't like that. And this is an important sentence in depression, different from sadness. People tend to say, "I wasn't like this. I can't. This is not me. I can't recognize myself. This is madness. This is dementia." With dementia, people lose memory, they can't focus, they lose their reasoning power. Depression can paralyze you. Sadness won't paralyze you. Sadness will get you down and make you think, make you more thoughtful and quiet, maybe. But depression paralyzes you. And in addition to the mandatory symptoms, there are some elective symptoms. And that's why when we go to Google, we think we have all diseases at the same time, right? If you go to Dr. Google and start to fill out the criteria, you may think you have attention deficit, you're bipolar, you have depression, anxiety, schizophrenia, and all other diseases that are available online. So I strongly do not recommend Google for mental disorders. That will only make you more confused. So I tried to prepare this chart just for educational purposes. Real life is not like this, but I just wanted to prepare this to show you more about the rationale behind what psychiatrists do. Many people come to my practice and they say, "I don't know why I'm feeling this way. I like my job, I like my family. Why am I feeling this way? What's wrong with me?" And then sometimes depression comes even if there hasn't been any loss in your life. You may be having the time of your life, your finest hour, you may be hardworking. Because in the past, people you'd say, "Oh, you would only be depressed if you have too much free time, if you're idle. If you're idle, you'll be depressed." I've heard that a lot. That's prejudice, that's discrimination, that's wrong. So I could be teaching you today feeling sad. I would have come here anyway because I know who I am. I trust my expertise, I trust my experience, I know the books I read. I could be here, I could be sad, but I would be here. If I was depressed, I would contact the organizers and say, "Oh, I can't go. I'm sorry, I just can't." When you're sad, you just change gears and get the job done. If you're depressed, you don't. You feel paralyzed emotionally, physically. I've never seen a sad person think about suicide. You're just sad, right? And if a sad person thinks about suicide, they will be afraid of this thought. Thinking about suicide and feeling afraid is a good sign, but thinking about suicide and going online to look for ways to take your life, that's a bad sign. That's a red flag. So sadness lasts a few days and then it disappears. A friend drops by and takes you out to have dinner or have some beer. You just go. After a few minutes, you're feeling good again, and then you think, "Oh, thank God I came." Bingo, no depression. It's not depression. We're just sad, down, got the blues. Normal. But then depression lasts weeks, months, and nothing can cheer you up. Even if it's a great party, if the party is good, you'll feel worse. And if you're in Paris, you would just want to jump from the top of the Eiffel Tower. If you try to cheer up, nothing can help you. And that's difficult for those who are next to you because they come and say, the families tell me, no matter what we do, we can't cheer him up. And then they start feeling upset and angry at the depressed patient. Let's look at some clinical cases, and you're going to help me establish a diagnosis. Amanda was a 24-year-old girl. Her parents lived in the U.S. She came back to Brazil, and it was good to be far from her parents. She felt free, she was independent, she was living by herself, and she was also distant from an old boyfriend with whom she had a troubled relationship. So now freedom opened up her horizons, but at the same time, freedom gave rise to conflicts that were silent until then. She complained about sadness, anguish, and she didn't want that to last longer. She wanted that to end. What do you think? She was just sad or sick. It's just like life, part of life, or a disease. Should we give her medication? Of course not. Of course not. And we have to be careful about that because young patients are they want a solution right away to pass their exams, their SAT. If they get dumped by a boyfriend or a girlfriend, they want medication for everything. So we have to be careful because kids are there's this medicalization of our suffering, which is actually normal. We're here to suffer. Suffering is part of life. We won't, no one can be happy all the time, right? We have to learn how to deal with this suffering. Teenager. A teenager gets involved in an argument with his parents, locks himself in his bedroom. That's normal. But let's look at this. Let's look at this girl. Dora says, "I haven't rehearsed with my band in 4 months." She loved her band. She hasn't practiced in 4 months. She feels that the world is stiff, distant, in slow motion, blurred. Everything is moving in slow motion in her life. She feels she can't swallow her food. She feels this thing in her throat. Even food has changed. She feels she's bad. She gets the impression that she's worthless. In school, she feels like an outcast. She feels cast out and with negative thoughts, bad thoughts. Everything is gray in my mind. I'm afraid to have relationships. I'm afraid of what people will say. I spend as much time as possible locked in my room. Is that a thing of life? Is that part of life? 4 months? No. This girl was a patient of mine. Of course, I'm changing things here, but with medication, in a month, she was back with her band. She was doing fine. Rehearsing, playing. Her life was normal again. A manager, sales manager, good-looking, handsome man, well-dressed man, an extrovert, 47 years old. One day he came to my office and said, "I've always been hardworking, I've always been a go-getter, but for 2 months now, I have dragged myself to the office to visit my customers. I feel tired all the time. I don't want to shave. I don't want to shower. I'm also concerned about my eldest son. I get the impression I didn't educate him well. I'm afraid he will do drugs." And then I met his son at the end of the appointment. Handsome boy, going to college. His son was fine, but he was imagining things and he was anticipating what could go wrong. Also, they had bought a plot of land. They were to build a house, and he was like, "Oh my God, I can't afford it. Why did I buy it? I'll never be able to build a house here. I won't ever have the money." He was so afraid of things that he needed his wife to hold his hand to sleep at night. And he had never been like that. 2 months ago, he was fine. He was doing his job. He was buying land and coordinating people. Depression. Depression. This case is chilling. This, if you saw this woman, there was no way you couldn't stop and look at her. A very pretty woman, well dressed, fancy, in fashion. She had many boutiques, always well dressed, with a dazzling catwalk. Now, I'll let you read. See how sad it is. My stores demand me to wear flawless makeup all the time, and I also have to dress perfectly every day. I incorporated that. I am a great hostess. I'm always smiling. I spend all day jumping from store to store. And then one day, being in two places at the same time, when you start reading it, you get the impression there's something fake about it. And then she says that when I get in the car at night, I cry. And then when I get home, I drink. And I'm alone at night and I drink. And I look in the mirror and I think about throwing myself out of the window of my condo. So there's depression, there's loneliness, there's alcoholism. That's an easy, and then there's an easy way to kill herself there. She could just jump out of the window. So at high risk of suicide. This old lady, a charming old lady, 78 years old. She looks like a granny, a sweet granny, super sweet. And then one day she told me, "I don't want people around me anymore. I can't stand stand people anymore. When someone knocks on the door and I see it's my grandchildren, I get chills down my spine. And then I try hard. I set the table for some coffee, but it doesn't feel the same. I would rather be alone, quiet. I'd rather be left alone. I want to be alone. Don't I love them anymore? What happened to me? I'm so embarrassed. I'm so ashamed. I don't love them anymore. You probably think I'm a terrible grandmother. And then I remember I asked her, ma'am, are you sad? And that's exactly what she said. I'm going to try and imitate her, right? So she said, no, doctor, it's not that I'm sad. I'm just different. Bingo, depression. I gathered many quotations and sentences from my patients. First, when you're depressed, you think you're strange. You realize you're different. Also, when you're depressed, you feel something has changed, your affections change, your feelings change. Sometimes depression is not followed by sadness, but by bad temper, short temper, alcoholism, alcohol abuse to calm down. Negative thoughts, negativism, negative thoughts. So, some say, if I got cancer, it would be better. I was in ICU for 3 days and I couldn't die. I couldn't even kill myself. Like, yeah, even I failed, even at that. One woman, a patient, a female patient, once said, "I saw a beautiful dress at the store the other day, and I just didn't want to buy it." Their behavior becomes different. They feel stupid. They get rude. They resent other people's happiness. But these are unusual feelings for most people. Sometimes it's your body that suffers, especially among senior citizens. They're usually more quiet. The elderly keep themselves. They feel physical symptoms like in their stomach, in their strange taste in their mouth. And if you ask them, are you sad? They say, no, I'm not sad, I'm different. Senior citizens, the elderly, have different manifestations of depression. And then finally, uh, um, it's depression that leads many people to suicide. So a brief rule for you to keep in mind. It's the acronym ROC, R for risk. Pay attention to the risk. Sometimes we fail to notice that someone is thinking about killing themselves because we don't want to see that. We don't want to notice that. We're going to feel responsible and not know what to do. So we have this psychic blindness and we fail to see it. But pay attention. Look at the changes in behavior among your friends, your coworkers, your partner, your children. Just look at the changes in their behavior. Pay attention to the risk. Mind the risk. Care about that. And then the O for listen, and then you ask and you listen without preaching, without shaking the person, without bucking them up or encouraging them up or cheering them up. Oh, you have to get better. You have to do something. You just have a beautiful life. That's bullshit. That doesn't help. That doesn't help. It's just, you have to listen in silence without judging, without frowning on them. Don't do anything. You don't have to do anything but listen. Listen close. Time is invaluable today, and therefore attention is invaluable. And that's one of the most precious things there is. Giving someone like 10 minutes of your time is priceless. And we cannot be paralyzed. So we have the C for conduct. There's no point in giving them a tap in the back and say, oh, promise me you're going to take care. Promise me you're going to get better. A depressed person cannot even take a shower properly, let alone scheduling a medical appointment. They won't go to the drugstore, take medication. So if you're depressed, you need practical help, not moral help. Moral help doesn't help for depression. It may help for sadness, for when you're down, but when you're depressed, you need help getting treatment. So look at the risks, listen carefully, and conduct them. Help them. make sure they get treatment. And that was it. These are my books. I think they have some interesting content for you if you want to learn more about depression, how depression paralyzes people. And I also have some posts about anxiety and insomnia on Instagram. Follow me there. Thank you. Thank you, doctor. Thank you. Brilliant as always. And now, let's change the tone of the conversation. Dr. Marina is a doctor and an educator, and she's been working on this fascinating idea that can help us individually and it can help us as caregivers. So, how to change a tragedy into something positive, how to change disgrace into something positive, how can we deal with disorder and post-traumatic disorders in general. Dr. Marina, the floor is yours. Thank you, Professor Bertolotti and Professor Bottega. He came here as a professor, as a teacher, and I came here because I'm so short that if I don't stand on the stage, you'll never see me up here. Anyway, I'm going to talk about post-trauma stress, and it's also totally related to the topic of this roundtable. Society today has this axis. It's either success or failure. And there's great pressure on everyone to achieve success. To be successful in terms of health, in terms of knowledge, in terms of having things. But what we see is that regardless of what extreme you're in, there is depression, there's violence, there's corruption, there's prostitution, there's promiscuity, there is dependency, addictions, not only drug and alcohol, but also cell phones, right? That's also a form of dependency, regardless of you being successful or a complete failure according to the criteria here, regardless of what end of this line you're in. There's healthy and unhealthy people with depression, suicidal tendencies. And why is that? Because it's not that simple. Our life is not like this single axis, this single horizontal axis. We have the vertical axis, which goes from the emptiness, the void, the despair, to the accomplishment, to fulfillment, to attaching meaning to things. So when I live fully as a human being, when I'm not reduced to the success-failure axis, then I can't really, I don't stand a chance. But when I achieve that dimension here, I'm sure you're all familiar with that. I'm sure you all know successful, healthy people who are apparently doing fine, but they're desperate. They have this existential void, this existential emptiness. And at the same time, I'm sure you know people who are apparently a failure, but who are fulfilled and their life is meaningful and they are at peace. If we're here, we expect to be here, right? To be successful and accomplished at the same time. Fulfilled. Successful and actually fulfilled. So let's work on this idea from another perspective. Anywhere on planet Earth, rivers are drawn to the sea, right? It's a force. It's a physical force. We can't avoid it. Sunflowers are also drawn to the sun. Anywhere on the planet, they turn to the sun. Parrots are attracted by fruit, and I see this in my house's backyard. I'm sure you're familiar with this green parrot, that it's everywhere. It's everywhere. So wherever there's this yellow little fruit, there will be parrots. They attract each other. So what attracts human beings? What draws you with the power that, like, what makes you turn it to it, like the sunflower turns to the sun? this Viennese Austrian psychologist said human beings are drawn to meaning. We're drawn to meaning, and meanings draw human beings with a strength greater than that of the sun attracting the sunflower. And he says that the heart of man is not fulfilled and cannot rest at ease while it doesn't discover the meaning of life. Human beings are originally driven by the will by meaning, not pleasure, not doing. Not to say that they're spiritually directed by the aspiration of this possible fullness. And this is ontological, this is human. We all want to live our lives to the fullest, to explore all our potential. To attach meaning to things, to experience this wholeness, this fulfillment. And when we lose that, when we lose meaning, when this will is frustrated, then we have other types of drives. And this sentence is very powerful. Men want meaning. Perfect. We all agree with that. But there's not only one meaning to things. Men are also free to follow this meaning or not. Sunflowers can't do that. Sunflowers cannot say, oh, the sun is beautiful today, but I'm not going to follow it. But human beings can do that. We can, or sometimes we can do that when we're attracted, we're drawn to something, but we may say, no, I don't want to do this task, I don't want to do this work. Like here at Free Mind, we can be drawn to it, but we can say no, we can say yes or no. We have this free will that sunflowers do not have. So let's play a game here. Let's do this exercise about meaning. It took me forever to understand this meaning thing, so don't worry if it's still a bit cloudy for you. I want you to think of a task, an activity, something that you really that you knew it had to be done, but you didn't want to do it. I have many things like that, and many things I know that have to be done, but I don't want to do them. And you were convinced that you wouldn't handle it. You didn't have the money, you didn't have the time, the health, the knowledge. You didn't have what it takes. But then the calling was so strong, that attraction was so strong, you were so drawn to it that you went there and you did it. How did you feel? Joy, what else? Satisfaction. It was great. You felt accomplished. Well-being, completeness, fulfillment. It even increases our self-esteem. Like, oh, I did it. I was capable of doing it. Now think of the opposite situation. You were drawn to it. You knew it had to be done, but you didn't do it. After you missed the opportunity, how do we feel? And then we feel sad. Sad. Indeed, we do. What else? We feel sad. We feel ashamed. We feel regret. So what you felt the first time is the consequence of the fulfillment of the meaning. When you fulfill this meaning that comes from your consciousness, it's not imposed upon you. It's not that what you want from the world is where you're drawn to. You know, I love this sculpture here. It's about this void, right? This is a consequence of this rejection to this call of meaning. It's the deprivation of that, and then you deprive yourself from joy, from satisfaction, from the accomplishment that were waiting for you if you turned to the sun, if you fulfilled that task. And what are the symptoms, the consequences of this frustration, of this denial of the meaning? When you use your freedom to deny to say no. So the symptoms of this void, of this emptiness, are boredom, lack of interest, apathy, lack of initiative, depression and suicide, violence, dependencies. Here we're focused on suicide and dependencies. So let's see what we can do about that. I like this sentence very much by Mr. Viktor Frankl. It says, someone who is looking for meaning and fulfills this meaning. We're thinking about the vertical axis, right? The person axis. Then at the same, this person becomes happy and capable of bearing suffering at the same time because there's meaning in suffering. There is, Professor Bottega said that, and that's absolutely true. If you've never loved someone for real, you've never suffered, and then you suffer even more because you have never loved someone. But still, that's for another session. So suffering is part of life. If we do not find meaning in this suffering, we're doomed to be unhappy. So what is the healthy path for us as human beings? We have to think about who we are, and we have to look to what we can be, the meaning we can fulfill, and achieve, and the consequences will be joy, pleasure, success. And those will be the side effects, the consequences. Power, money are a means for us to achieve meaning. If you say no to the attraction of the sun, what will happen? No one can live without happiness, without joy, without pleasure. We pursue pleasure full time, right? And then we will pursue fast pleasure just for the sake of pleasure in itself. But then it's a deviation. It's a shortcut, and then actually the distance between what we are and what we want to be increases, and then we start spinning around in circles inside, and we should spin outside. We should spin outward, not inward. We should not be self-centered. We should look out into the world. Of course, there's a solution for that. When the distance is short, education can be our best tool. And that's why I'm going to talk about education in a minute. When the distance is long, then we need psychotherapy. And then we can go back on track and recover the joy in life. She was a direct disciple of Viktor Frankl. She lives in Vienna, Austria, and Vienna. And here she talks about destiny here, but as reality, right? Not the destiny in the future. It's what's happening already. So any destination or any destiny, no matter how painful it is psychically bearable if it can be put in a context of meaning that can be acceptable to us. Conversely, everything may be fine, but not even the best conditions are bearable if life itself has been destitute of meaning or been perceived as destitute of meaning. Now, let's see how we can apply this to primary and universal prevention according to the definitions shared by Professor Neri. So according to the logotherapy idea, there are three main pillars. The anthropological pillar, it talks about the freedom of will. We're not predetermined. There's the freedom of will, free will, the freedom of will. There's this will for meaning, this desire for meaning. We used to say that in Freud's times it was a sexual repression, but now we have existential repression. That's also a topic for another talk. And then there's the meaning of life, which is a more philosophical worldview. In education and in psychotherapy, we work with this will of meaning. So this search for meaning. So what do we do then? Even depressed people have this will to find meaning and to accomplish meaning, even if it's muffled, and to make it grow. We want to make everyone find meaning in every situation, and this love of life find meaning even in suffering. If you find meaning in suffering, you'll find meaning in creation, you'll find meaning in everything. So this preventive work, primary prevention, helps people discover in concrete situations, in the here and now, because you cannot find meaning outside here and now, the perspective of accomplishing meaning, finding meaning, and then you have to change this funnel view, because suicidals have this funnel view, to this fan view. So you can see all the possibilities, the countless possibilities, this range of possibilities, as if life was a fan like this. It only ends when we die, and then there are no more opportunities. But until then, there will be. And then the will to meaning, where the will to meaning is unconscious, we have to spur it and encourage it and even summon it when it's repressed. We have to sharpen this will to meaning. Let me give you an example of something that happened in 2015 at the school. We were doing this work on the importance of sleeping well, institutionally speaking, but still. So, still, there's a whole team here, the administrative team, and then there were 3 students who didn't want to join the project, they didn't want to do anything. But I knew that one of them played the guitar, and we didn't have music, and then I asked them to come up with a song. I challenged them. Because I thought there should be, that I believed in the will to meaning, and they came up with such a beautiful song. It was memorable. It was an event at the University of São Paulo. It was even, this project was even presented at the Medical Society, the Sleep Medical Society. And then in 2019, we had an institutional campaign to try and expand the scope of this notion. And in 2019, we worked with cell phones, the conscious use of cell phones, smartphones. So we trained them for that. We prepared them. We came up with a committee. The committee did some research, and then they spread the word inside the school. It was a private school at first, and then we took it to public schools. And it was great. And those kids were so excited about it because they found meaning in what they were doing, and this was very effective in prevention terms. This is true prevention, deep prevention. 2019. And then in 2020, we worked with gratitude, and gratitude and suicidal ideation, because in this gratitude, if you're grateful, you have better self-esteem, and you attach greater meaning to life, and with that, there's a decrease in suicidal ideation. You can teach gratitude. You can teach people to be thankful, the importance of being thankful, even in hospitals, right? And we did this online in 2020 during the pandemic, right? Last year, we worked with love and forgiveness, which was also very beautiful, very touching. Our children are the parents of the children, our students in school, they all came up with quotes and sentences and sayings. So find us on Instagram and follow us, because there's some nice things there. This year, our campaign is focused on peace, working on that, and this is what we're doing. This is currently work in progress, working for peace with topics that are about prevention in themselves, topics that help prevent drug abuse, alcohol abuse, and suicide. It's also silence, sleep, gratitude, love, forgiveness. We have art works created based on those topics. Last month we had a meeting with students and parents to think of joint actions involving students, community, parents. It's not over yet. It's brand new. This meeting happened Last week, so older students were teaching younger students, and the topic of this conversation was silence. So we also give them we empower our children in our school. They need to feel useful for the others outside, not focused on their own needs only. They have to know that they're necessary for a better world. And to finish with Frankl's quotation, he said this in a concentration camp. He said, despite everything, there's life. Yes, there's life. And now I will invite you to, I want you to listen to what your consciousness says, what you have to do, and put it in practice in the best possible way. And now I may say, I want you to listen to what my consciousness is saying. He said yes to life in spite of everything. So I have hope in a better world. I firmly believe in a meaning-oriented world. So thank you very much. Thank you, Dr. Marina. And now let's listen to Ms. Silvania Girondi. She's a social worker. And before I hand it over to her, let me tell you a story about Silvania. She used to work in a big company in the city of Botucatu, upstate São Paulo. And she worked in a big corporation there, a big company there, and she did some outstanding projects there, some mental health campaigns, so much so that suicidal ideation there was completely eradicated. But then other people would come to her and share their concerns about suicidal ideation in other places. And then one day she was bold enough to convene a meeting in downtown Botucatu and started talking about suicide prevention. I went there. I thought it would be just the five of us. It was an auditorium from 150 people, and it was crowded. And then after that, Silvania created a movement called Preciso de ajuda, need help, Silvania, the floor is yours. Thank you for the kind introduction. Indeed, that auditorium was crowded. I'm very happy to be here. Dr. Bertolotti is a dear friend, and I've known Dr. Marina for a long time. I'm very, very happy to be here with you today. Thank you for joining us. And now, let me, just a second, right. So to talk about the Life Protection Network, first I have to tell you a little bit about the projects we did in a large company. It's a large company with about 5,000 employees. This plant in particular has over 3,000 employees. Inside that factory, we've had many projects, many programs over the years, over decades. And then what we noticed is that the employees who participated in the programs achieved better results. For over 14 years, no suicides occurred, and that was impressive because the company had a bad track record with suicides. But then the families of those employees continued to commit suicide every now and then, and that made us think about that, because and then that made me think one day, there's no point in having it in here, only inside the plant. We have to expand it to the community, and that's when I had the pleasure to meet Dr. Bertolotti, and we presented some of our programs to him, and we realized that we could expand them to the rest of the community, not only inside the plant. And then the network was officially created in March 2016. It was the date when we had that crowded meeting in downtown Botucatu. We started with three main programs. This one that we call the Well-Being Program, focused on treating depression with physicians, psychiatrists, social workers, psychologists, group therapy, individual therapy, changing employees to different departments, changing shifts, not only psychological support, but also medical support, emotional support, and spiritual support. This program started in June 2007. It's focused on the young, from 15 to 17 years old, mainly. It's focused on the young to prepare them as citizens, and those who stand out are hired by the plant. Another program that I'm very proud of is the Missions program. It's a program focused on spirituality within the plant. We had 17 prayer groups that would pray every day, and there are more, of course, but these were the first. So these programs were very helpful to help us to address suicidal ideation, and based on these three main programs, we came up with a program for the community with volunteers for suicide prevention. And then we came up with the Rede de Proteção à Vida, the Life Protection Network. It's a multidisciplinary group of healthcare professionals with mental health, physical health, spiritual health, education, sports, media, law enforcement, firefighters. So in this network, there are professionals from many industries and members of the community, housewives, the mayor, politicians in general. It's open for the population in general, whoever wants to work as a volunteer in this project. So you can help in many ways. If you want to help with suicide prevention, there's always something you can do. You don't have to be a psychiatrist, you don't need to be a psychologist, you don't need to be an expert, but there's always something you can do. You just need this will to make a difference, and of course it takes some training, some knowledge to do your best. The first activity that was carried out by the network was this Yellow September. We started these initiatives in 2016, and there back in Botucatu we have many initiatives. You can see some here. There's dancing, spiritual activities, races, Reiki, photo exhibitions, music, concerts. There's a lot of cool things over the month of September. And we make some partnerships around the city so that people can stop, take the time, and think about how good it is to be alive. And this is our flow chart. We have professionals from many areas, like I said. So if you want to receive treatment, you can go to our website, and you're going to be screened by a first team there. So it's the screening team. There's a professional who receives the request, refers that or forwards that to the screening team, and then the screening team or the welcoming team will monitor the patient for at least 6 months. Over the phone talks, there's an interview, they check up on you every now and then, and depending on how you're doing, they will refer you to treatment. In some cases, you can write down what you want, and then sometimes with 2 or 3 welcoming sessions, you start feeling better. So it's all it takes. You receive what you need. In just a few sessions, you feel welcomed, you feel important, and all of a sudden, you feel better. The problem is gone. It's gone. The problem just start looking so much smaller. And then there's also alternate therapies, spiritual supports, and also, of course, the group of professionals. We have therapy groups here. The most severe cases that require psychiatric treatment are referred to the public healthcare system, the SUS. In the Life Protection Network, we have some coordinators. One of the coordinators is Dr. Bertolotti, myself, Marina, and Marcio Machado, who is also in the health department of our municipality. And then we have professionals that facilitate referrals whenever they're necessary. Referral for medical care or hospitalization commitment if necessary. But sometimes these requests for help do not come online. Sometimes we find out that someone is thinking about committing suicide on Facebook. We had a case in Botucatu the other day, 6 kids agreed. They started texting on Facebook, arranging to commit this collective suicide. They will jump from a bridge together. And then when they found that out, when someone found it out, they texted us and they told us they texted us that was happening. And in less than 15 minutes, there was a professional with these kids. And there are many other cases. And then we can solve that in a few minutes because we can also use the internet to our advantage. Of course, it can be a problem, but we can also use it. We can harness the potential of the internet to our favor. We have many WhatsApp groups. We have a group of supporters. And who participates in this group? Anyone who wants to support the network. No need for specific training. All you have to do is when you know someone needs help, you'll post it you will text us on WhatsApp, you will put it on our WhatsApp group, I think someone is thinking about committing suicide. You just text us there, and then we articulate ourselves to take action and support whoever needs support. So we have activities, we have a schedule with training programs, training sessions, education, and there are some pretty cool groups that involve everyone from housewives to the mayor of the city, professionals from every area you can think of. And this group, professionals who are there because they're volunteers. They do it because they want to. They just and sometimes your responsibility is to check your Facebook. And if you see someone needs help on your Facebook, for example, just text us there. But this has already saved many lives. About 7 months ago, gentleman, almost 50 years old, posted a bottle of beer, a bottle of liquor on Facebook and a gun right next to it and said, "This is my last post." And then one of our supporters saw that and he texted us on WhatsApp immediately. We found out who that gentleman was. We went to his home, we spoke to him, we spoke to his brother, so we spoke to his family. So it's a great group. We have saved many lives already. There's also the second group, the group of professionals. And then in this group of professionals, of course, there are only professionals like psychologists, social workers, doctors, people who actually dedicate some time for this assistance. It can be individual sessions like psychotherapy or collective sessions. There's Reiki, there's dancing, tango, massage, many activities that can be. For free care, free assistance. And the third group we have is for spiritual assistance. And there we have priests, pastors, people from evangelical churches, Catholics, spiritists, and Protestants. So when you want support, we ask you, do you have a religion? Yes, I'm Protestant. Do you accept someone to visit you? Are you okay with someone visiting you at home? Yes. And then, if so, they will receive this spiritual support. And with this spiritual assistance, we help them rekindle their faith, recover their faith. We try and bring them back to church. Sometimes if they're having financial problems, church can help them. The church can help them get a job, so they feel sheltered, welcomed.
Our fourth group is the media group. Within this group, we have professionals from different areas. Radio professionals, TV professionals. So whenever there is an activity of the network, they advertise it. And if there has been suicide, they will not advertise. They will not publish anything. They have been guided on how to behave whenever suicide happens. The fifth group is made of heads of public and private schools. If there's any kid who committed suicide, or if there is children mutilation, they're self-mutilating, they contact us, and one of our professionals visit the place. Sometimes we visit schools randomly, and sometimes we go specifically to address situations. We have many different examples of situations with teachers, and then only directors of schools, and then there are joint initiatives, parents and teachers. Here is a sheltering group. This group of professionals remains 6 months with the patients. We have a monthly meeting with the Dr. Bertolotti and with the professionals to discuss cases. We have supervision. Group 7th is an ecumenic prayer group. The people who are sheltered by the network and want to keep on praying, they can join this group. They pray 24 hours a day. You know, sometimes someone will text saying, "Oh, my uncle is at the hospital," so everybody starts praying for this person's uncle. So this group prays 24/7. Group 8 is city government network. Within this group, we have the mayor, their secretaries, and sometimes we need a place to perform an activity, or we want to close a street to perform something. Everything that we do is through this group. We have very good communication with the public government. They believe our work, so we easily communicate with them. The 9th group is the group of ambassadors. We train young people from 15 to 17 years old, and they are turned into and the ambassadors of the cause. So they learn how to deal with their emotions, and they understand how to read the emotions of their friends. When they see somebody's in need for help, they will contact us, and we will get in contact with this young person's friend. It's much easier for a young person to convince another young person than an adult. So these are the groups that we have in our network. We are very pleased to share with you how pleased we are for helping prevent suicide. Thank you very much. Thank you very much, Silvania. We still have a few more minutes, and maybe if someone from the audience wants to ask a question, feel free. But I would like to highlight something. We are 4 professionals with very different education backgrounds. We work on different projects, and although we use different languages, we have something in common. We work on a common project. So I invited these ladies, these colleagues, because I wanted to give you a sample of how we can develop initiatives, and then how can we put initiatives into practice. So, ladies and gentlemen, if you want to make comments, if you would like to ask a question, please identify yourselves. So tell me your name, where you're from, and your question. My name is Janete. I'm from Paraty, Rio de Janeiro. Well, any of you can answer my question. I would like to ask something about the internet and cell phones when it comes to communication of young people. So there was a moment in which the internet encouraged self-mutilation and suicide. Do you think that the internet and the cell phone communication contributes for this? There's a book called Engenha, and she made a survey in the U.S. and she showed statistics that showed increase in the number of suicides, especially after the development of smartphones. Cell phones are very good. I'm not saying that. I'm just talking about the excessive use. We have to use our cell phones consciously. What really scares me are parents who put their really young children in front of screens. There are so many studies showing the negative effects of screens for children on understanding and concentration. When the pandemic started, we wanted to we had to continue the programs. We developed an online program and the results were fantastic. We didn't work with the young people alone. We worked with their families. So I think that if we use the internet on our favor, we are going to have fantastic results. Of course, there are people who don't use it correctly, but we can use it as a positive tool. We can use it to bring families together. Young people, they like challenges, and they always bring us very interesting results. Good afternoon. My name is Ana Paula. I'm a social worker. I am very happy for being here. Good afternoon, everyone. Your lectures were wonderful. I'm a public official of the city government of Campinas, and I work in basic social protection, and prevention is our motto. With regards to suicide, specifically speaking, I will ask the three of you, any of you can reply to me. Is there any study that you can talk to us about? We talk about suicide a lot, but we focus on an individual level. We talk about disorders and individuals who feel guilt. Oh, I am not capable. I wasn't able to deal with it. But I also see suicide as a social issue, especially after the pandemic in the current day. I think it is a collective issue. I don't see suicide as an individual problem. It ends in an individual case, but it has been increasing amongst elderly people. But I think that it is something collective. Does any of you would like to talk about this? At the end of the 19th century, one of the fathers of sociology is Emilio Durkheim. He wrote a book called The Suicide, and he said, suicide is a social fact. He classified 4 types of suicide. One of them was named after selfishness. So this is the one that you mentioned, the individual suicide. Something that I think is extremely fascinating about suicide is that, first of all, it's the only exclusively human phenomena. No other animal on earth commits suicidal. And suicide has been a philosophical, mental, psychological, social, legal problem. You can analyze suicide from many different points of view, and we have many different ways of addressing suicide, and suicide can be what a person wants to see. You work in the public sector. I work in the private sector as well. And many of us work in the private and public areas. We have to recognize the risk. And when each one of us recognize the risk from the place where we work, those who work in practice office exclusively will only acknowledge just their individuals. We will only be able to face suicide if we address it with a multidisciplinary point of view. We have to understand how can we improve our performance. This is worth for suicide, drug abuse, depression. So how do I improve response to programs? Sometimes individual interventions will save a life. In other moments, collective intervention will save tea. If we remain closed down in our specific areas, everything's going to be harder. So there's clearly a group that sees suicide as a collective thing. Durkheim says that suicide is the result of anomia, a social situation in which rules disappear and people lose hierarchy and lose ways of communication. Here in Brazil, we live in a situation of extreme anomia. What we see the most is confusion. We have 3 powers, and the 3 of them are trying to destroy each other. We have the legal branch of the government and the other 2 branches, and this government works on a top-down perspective. And suicide has been growing immensely amongst young people, and they need guidance. And Brazil really lives a situation of anomia, and we have to find ways of reverting this process if we want to hinder the process of increase in the numbers of suicide. I started reading Durkheim again. I recommend all of you to read him. I'm Renata, a professor at Unicamp University. I would like you to talk about prevention in the special context of drug use. This is my dear Renata Azevedo. She's a friend and she's a professor at the University of Campinas. She dedicates her life to treating people who have problems with addiction. Bertolotti mentioned Durkheim as one of the fathers of sociology. The suicidology also has a father. His name is Edwin Schneider. And he says that in order to think about suicide, we have to think about two continuums. One is psychic disturbance, and the other one is the intention to put an end to life. This is why there are so many people who suffer from severe mental distress, but don't think about killing themselves, because these things don't always walk hand in hand. But there are some people who think very frequently about committing suicide, even though they don't have a mental disorder. What is common is to have an association of severe mental disorders and an increase in the desire to commit suicide. We, as clinicians, don't see depression in high levels, but we see the lack of meaning, the void. Sometimes there is a narcissistic wound. Something happened in the person's life and they are not able to recover. They carry that wound that will never heal and keep on bleeding and bleeding. People who are dependent on chemical substances, they are not thinking of suicide consciously because there's pleasure there. If we say that Ayrton Senna was suicidal, it's nonsense. Sometimes even healthcare professionals say nonsense like this. These people, they are not willing to kill themselves. Of course, there is a self-aggressive component, and it can change after setbacks in a desire to kill oneself. So it is possible to have the will of ending one's life without severe mental disorders. Sometimes a person falls apart as a result of something, an event, but sometimes when this person falls apart, they stop using drugs because they've reached their limits. It seems that some people, until they don't achieve a limit point in which they almost die, they will not stop using drugs. For some people, it's really difficult to free themselves from drug abuse. Very difficult question, Renata. This is Paulo Martelli here. I have to wrap up. I would like you to stay for 10 more minutes because I have 4 friends here who almost wanted to kill me because I was going to wrap up the day. So, Dr. Bertolotti, please, let's wrap up for today. So, on behalf of Paolo Martelli and Free Mind and my the panelists, I would like to say that it was very inspiring to see how concentrated and focused you were during our panel. Thank you very much. Count on me for free mind, for future events.